chair of the PEBB board. And before taking roll call, I do want to just say a couple things about our agenda today. We have a number of action items, and I just want to be clear that it's important that we have discussions and are ready to make decisions on our action items. And it may be that we need to make some of those decisions in May if we need further information. So we do not have to make all the decisions that are lined out today if we determine we need more discussion or more information. We do have to make all of our decisions by the May meeting, however. So just want to be clear on that. I'm going to start us off with a roll call. And I don't have my sheet right in front of me. So I thought I did. Take a moment. There it is. Okay. So Dawn, are you on the call? I know we heard from Dawn this morning. Oh, yes, yeah. Dawn Mottner, are you here? Great.
Yes, ma'am. Thank you.
Yep, thank you. Greg, I can see you. You're here. Chicky, I saw you get on. Chicky?
Good morning, everybody. Chicky Flowers here by video and phone, I think.
Good morning. It's working well.
Okay. Good morning.
All right. Andy, I see you on video.
I am here.
Right. Thank you. And Kimberly, I see you on video.
Good morning.
Good morning. I believe Kate may be able to join at some point. I don't believe she's here yet, but let me give her a moment. Kate Nass. Okay, I don't think she's here right now. Sean, I see you on video.
Good morning.
Good morning, Sean. I believe that Representative Nose is busy in the House and not able to be here because of the legislative session. I'll give Representative Nose a moment. I don't believe he's attending today. All right. Well, we do have quorum. Oh, Kate, great. You are here.
Sorry, I was a little bit late.
No worries. You got here right at the end of roll call, so you made the roll call. All right.
Thank you.
And we are going to get started just getting used to all of the decisions we'll be making today. I do need a motion for the minutes, both for last meeting, so the March meeting, as well as for the February meeting. We didn't have quorum at the beginning of last month's meeting, so we are delayed in approving the February minutes. So I would like a motion for the February and March minutes for approval. Do I have a motion?
I can make that motion.
Great. Thank you, Greg. Do I have a second?
This is Chicky. I can second the motion.
Great. Thank you, Chicky. All right. So, Dawn, how do you vote on the minutes?
Approve.
Thank you, Dawn. Greg, you did the first. Chicky, you did the second. Andy, how about you?
Approve.
Thank you. Kimberly?
Approve.
Kate?
Approve.
Sean?
Approve.
All right, thanks everyone. The minutes for February and March are approved. So I believe we are going right into the renewal responses, and that is going to keep us busy for quite some time this morning. And Andrew, I believe you're leading on that.
Yes, thank you, Siobhan. Good morning, board members. Glad to be with you today. As Siobhan said, we do have some decisions that we'll be asking you all to vote on, but more to come on that here in a couple of slides. This is the round 3 renewal presentation, and so these do represent best and final from the carriers. Today you've got myself and Emery and Sally per those names on the slide. We've also got Christy from our health equity team and Dr. Twang from our clinical team, so you'll be hearing from quite a few of us. We've got an hour and 45 minutes, so hopefully that'll be plenty of time. Hopefully I didn't just jinx us, but I think it should be good. But looking forward to a lively discussion as per usual. So thank you. Here's our agenda. So we'll start off as we always do with the renewal background, where we'll go through guiding principles, health equity strategic pillars, your short and long-term goals. I'll move through that section somewhat briskly just so that we can really spend the lion's share of the time today on the second section, which is the round 3 renewals. And so in that section, we'll start off by sort of outlining what are the remaining key issues as we look to continue working on finalizing renewals for 1/1/24. There's a couple of new content areas in that section around the public health emergency and related COVID coverage, as well as a life and disability renewal through the standard. But much of that section will be familiar to you as we go through all the various program and plan design changes that we've been reviewing each round thus far. The other renewal section will capture a few of your ancillary benefits, and then we'll talk about next steps as we prep for May. All right. As always, just stop me with questions. I'll try to keep an eye on raised hands, but Mercer team, I know you'll help me if I miss that. So I know everyone's familiar with this slide, PEBB's vision around healthcare and really guiding principles. This really drives what strategies the board wants to develop. And so these are bucketed into 3 categories around quality of care, the member experience, and efficient delivery of care. And ultimately, there are 3 groups we're trying to positively influence, the first and foremost of which is members, of course. The second is the organ delivery system, and then the third is the plan sponsor itself. And so these are aligned in such a way so that they're sort of embedded and aligned with the governor's priorities as well as the Oregon Health Authority's priorities. We want to jump to the next slide. We can review the health equity strategic pillars. The board has established that centering any and all decisions on health equity is really the sort of key strategy. And so just want to ask everyone to keep in mind that as decisions are being voted on today, really keep in mind all the conversation that's been had thus far around different populations that have been historically disadvantaged from a health equity perspective, and how each of these different program and plan decisions that you're going to be voting on might influence those folks. And then the third slide, which sort of serves as our preamble to today's content, is around the short and long-term goals. These were established during the retreat process in late 2022. Some of these goals, which are outlined in blue on the right, are more easily influenced through the renewal process. Others are sort of handled outside of the renewal process. But these goals include things like measuring plan performance and holding the plans accountable for both health equity and behavioral health, achieving plan equity across the state, focusing on whole person, member education and helping members become informed consumers of healthcare, addressing the needs of a diverse population, ensuring the richness of the benefit while managing cost. Obviously, that's a big one during the renewal process, and pursuing alternate payment models like value-based payment, that sort of thing. All right. And so this is our section where really we're going to be spending most of our time today. And we wanted to start off this section with this sort of introductory slide to really outline what we think are the key issues that remain and the key updates, again, as we look to get things finalized for 1/1/24. The first item here is me stealing some thunder from Emory, and that is that the composite rate is now coming in under 3.4%. And so as I'm sure board members, as you'll recall, during the last 2 rounds of the renewal, we were above 3.4%. We are now under 3.4%. And so in the next couple of slides, Emory will talk a little bit about what's driving that. But wanted to share that good news with you right up front. The next key issue is around low-cost plan status. And so the way that employee contributions are set up, each plan achieves low-cost plan status if there's a 10% delta in the rates between that plan and the most widely available high-cost plan, which is the statewide plan through Providence. And so currently in 2023, the MOTA plan, the Kaiser deductible plan, the Providence managed plan are all low-cost plans. As it stands today with projected 2024 rates, the MOTA plan and the Kaiser deductible plan will lose that low-cost plan status. And what that means, if when rates are finalized, if that remains for 2024, contributions for folks enrolled in those plans will go from 1% of the total cost of that plan to 5% of the total cost of that plan, which is a pretty big jump. We'll talk about what that deficit looks like by individual plan here today as well, so you can sort of see what that gap is today and what would need to be overcome to sort of achieve that low-cost plan status. But that is a dynamic that we'll want to keep in mind as we keep an eye on how the rates change up and down, depending on how the board votes on these various program and plan design decisions that we'll ask you to vote on today. The third key issue is around the Kaiser renewal. This continues to come in very high at 13.5% in total. You can see the split by plan there as well. And so I think we'll probably spend a good chunk of today's discussion talking about that. And then the fourth item is the sort of list of program and plan design changes that largely, we've been talking about through the first couple rounds of the renewals. Like I said at the outset, there are a couple new items around the upcoming end of the public health emergency as well as the standards renewal. But we'll continue to talk through all those items that we've been vetting with you over the last few months. And what we'd like to propose today is really to have the board vote on all of those items in category 4 on this slide today, so that we understand how the rates are going to go up and down based on those decisions. And then at that point, we can reevaluate which plans continue to not have low-cost plan status, so that in May, you can vote on if you want to use reserve funds to achieve low-cost plan status by essentially buying down those rates. And so this would be a two-step process where today, decisions where possible will be made on those program and plan design changes. And then in May, we'll look again at the deficits between the plan rates and have a discussion around if the board wants to use those reserve funds to buy down any rates. I'll pause there and see what questions or comments folks have so far. Okay. I know that's a lot to take in, so just as you sort of noodle all that, just raise your hand as questions come up. And with that said, if there are no comments, I will hand it over to Emery to go through the next slides on the composite rate.
Hey, Andrew, are you able to hear me?
Yes.
Okay,
Yes.
sorry. I think I was having trouble getting off mute a minute ago. So I did want to say that it may be the case that some of the plan design elements that the board needs a little bit more time, and that will come up during discussion. So I just don't want the board to feel like they have to make every last decision today if everyone's not in a place to do that.
Yeah, absolutely. Thanks.
Thanks.
Okay.
So here on slide 9, we have the composite rates for the most recent year, at least based on the latest projections down at the very bottom. We also do have the historical as you move up the table, so we can take a look at, I guess, the bottom 2 rows. So the final row is really the number that Andrew was talking to you about, the preliminary 2024 composite rate. And that is coming in at about 1771.78, which is a 3.2% increase over the final composite rate for 23, which was 1698. And so you do have, you are coming in about $2.5 million below the 3.4% target. So there is a little bit of wiggle room, not very much, but you do have $2.5 million below. So that's something to keep in consideration as we talk about the plan design changes. The reasons for the decrease in the composite rate compared to what we were showing preliminarily last month is due to two reasons. One, claims actually came in a little bit better for Providence Choice and the MODA plan. So those rates do drop, and we'll talk about that a little bit later in a couple slides. And also, there was a rate concession as well on Kaiser Dental, so that did help decrease the cost. But the other point was really this continual switching between plans. So what we did was to take a look at the March census, and the March census is used for the budgeting purposes. And every year, the members who come into PEB tend to enroll more and more into the lower cost plans, into like the managed care plans. And this continued for March compared to January. And so that increased I guess the savings achieved as a result of the enrollment. And so that gave you a little bit more room and brought down the overall composite rate. And so if we take a look at the March census and the 23 composite rate, mentioned earlier, it was 1717. Based on prior final. Using the updated census, you can see that it came in at 1692 there on the right-hand side. So that's actually, gave you about 1.5% additional room, savings, which helped with the 24 composite rate in this case. So you ended up not, along with the funding assessment that was applied last year, the additional switching helped bring down the overall cost for PEB in 24. Any questions? Okay. Yeah, Ali.
Just a quick question, Emery. So we can't we can't include the premium tax, like credit it towards the 3.4% test, or the opposite is true. Is there any significant factor one way or another regarding the taxes, fees?
No. We do list premium tax here, and I think really it came in 2020, and that's where you see like in the middle of the table where the premium tax is first listed in the year. And so overall, the change in that year was 5.3%. So you did get the ability to essentially ignore the impact of the premium tax, and so that's why it's above the 3.4%. The subsequent years after that, the premium taxes remains in. So that actually doesn't have a role in the overall composite change, but it is just baked in there.
Okay, perfect. Thank you.
Okay. So taking a look at the rate increases by plan, you can see the admin fees there on the left. Province Choice and statewide, the admin fee increase is about 2.9%. And then you can see the rate increase in this column next to that. So statewide's rate increase is 3.6%, which is basically unchanged from last month. Providence Choice did decrease to about 6.7%, and you can see the total projected premiums and then the impact on the composite rate there over on the right. So overall, the proposed admin fees did not change, but the rates did go down for Providence Choice. For Kaiser, you can see there's no admin fee increase listed there. We just showed the preliminary rate increase, which is about 13.5%. That's essentially the same as what was provided before. And so you can see it makes up 1.1% of the total composite rate increase in this case. The row below that is MODA. And so for MODA and Delta Dental of Oregon, you can see the admin fee is 1.7 and 1.5% respectively. Those are actually, there were some rate concessions there provided there. So those are decreased from what was shown the prior month. And the preliminary rate increases for MODA Medical, it's 7.0, which is a decrease. And then Delta Dental is about the same as where it was the year before, or the month before. For Kaiser Dental, they did come back with a 2% premium rate decrease in this case. So that provides a little bit of savings for PEB. Willamette, VSP, and the standard are essentially unchanged from the prior month. So overall, you can see the 3.2% composite increase and the share that each plan represents that increase, as well as the $1.2 billion budget projected for 24. On the following slide, thanks. This is, the point that Andrew was talking about in terms of the low cost plan. So for The non-OUS members, OUS has a different contribution structure. For the non-OUS members, as you mentioned, it has to have that 10% delta between the statewide plan and the other plan in order to achieve that 1% contribution. You can see there on the far right, Providence Choice does come in at 10.2% below. So with the updated claims, and you can see it's actually just below, meets that threshold. But then Kaiser Deductible and MODA, which are the two to the left of the Providence Choice, they're coming in about 4.8% and 8.1% below statewide. So they are not achieving that 10% threshold. And you can see the deficit that they, or I guess the amount of additional savings that they would need to achieve to get to that 10% threshold. So that represents about $2.2 million for all the members currently in the Kaiser deductible plan and $3.9 million for MODA. So if PEBB were to essentially, I guess, reduce the premium, like the stabilization reserve to bring down the overall premium, you can see it's about $6 million in total for those two plans.
So I just wanted to comment here, and I know that folks know this. We don't control the premium here at the PEBB board. That's something that's bargained over. So I just want to state that for everyone, since that matters, and it matters around plan design, and the PEBB board doesn't set the premiums.
Yeah. So any other questions or comments? Move on. Okay. Thanks. Andrew?
All right. Thank you, Emery. So this is one that is new, board members, in that we haven't reviewed this in the first few rounds, and this really is not related to the renewals per se. This is related to the end of the public health emergency, which will end on May 11th. So in a little bit less than a month. The public health emergency really dictated how plans had to cover COVID-related claims. So vaccines, testing, inpatient coverage, all of that. And so what we've done is work with your medical carriers to understand how will those types of services be covered as of May 12th once the emergency ends. And so we've broken this into the different service categories, which you can see on the far left. So vaccines, COVID tests, and then treatment at the bottom. And then you can see each of your three plans going across the top. And we're showing you what the benefit is during the public health emergency, which we're still in, and what the proposed benefit will be as of May 12th once the health emergency ends. And so we did highlight so generally speaking, there's consistency across the carriers in terms of how they're proposing to cover these COVID-related services, with the exception of over-the-counter COVID tests for Providence, which is why we've highlighted that one in that pink color. And so Providence has proposed covering over-the-counter COVID tests in full, whereas the other two carriers have proposed not covering those, which would be sort of a return to business as usual, where over-the-counter test kits would not be covered by the plan. And so, when we developed our recommendation at the bottom related to this specific item, we thought there was a case to be made for covering over-the-counter tests in full. It allows, members who think they might have COVID to avoid going into a provider, right? They can just sort of test at home. It sort of encourages folks to do that. Conversely, these tests are not very expensive. They're $10 or $12 a pop. And so there's also a case to be made, to say, well, maybe these shouldn't be covered by the plan. These are an over-the-counter product that are relatively affordable. And so there's also that perspective. The other piece that I'll say, and hi, Kimberly, I see you have a comment. I'll just make one more comment real quick. Kaiser did confirm that they are only able to cover over-the-counter tests in full if all of the other COVID coverage areas are also covered in full. And so what Kaiser is saying is that they can't revert, treatment, for example, from being covered in full to applicable cost share, while maintaining over-the-counter test kits being covered in full. It would have to be an all or nothing thing on the Kaiser side. And so to the extent that parity is desired across the carriers, that might sort of sink the strategy of, offering or covering over-the-counter tests in full. So I'll pause there. Yes, Kimberly. I think you're on mute.
So I apologize in advance if I should know this, but if the emergency is over May 11th or whatever, so May 12th we start this, does that mean that all these websites where you can get free tests, is that all going to go away? Is that what we predict out of the CDC and all those places where I've never paid for a test and I've never got them through Providence? I've got them magically in the mail free. I've got drawers full of them, right? Because there's so many of us in my family.
Yeah, that is my understanding, is it will be as of that date. Yep. So to the extent that you want to stock up, now would be the time. Although I don't exactly know how the expirations work on those kits, but it would be yeah, that's right, Kimberly.
They magically get extended. It's kind of funky how, oh, that's okay. Ignore that expiration date. Yeah. So anyway, it's all good.
Right.
Thank you.
Sure.
So Andrew, I'm curious if, so Kaiser's saying they can't do this unless it's all covered, all of these pieces are covered in full. And did they have a cost associated with that? And then is there a cost associated with MODA? And then Providence is just saying they're going to do it and no cost associated. And I was making the assumption that Providence would continue with the 8 over-the-counter tests, but there's no number there.
That would be a good detail to clarify. I guess I also had assumed there would be some sort of limit, if in fact Providence does cover these in full. Regarding that specific provision, I think the cost would be pretty negligible. And Emery, jump in if you disagree on that, given how low cost those tests are. When it comes to a cost impact on the Kaiser side, if all of those provisions are continuing to be covered in full, that cost obviously would not be negligible, but we don't know what that would be at this point.
So yeah, so in terms of the over-the-counter tests, I think there was definitely an initial worry that people would stock up considerably on those tests and use the 8 per member. That has not happened. And the savings as a result of having those at home versus going into the doctor and having those lab tests performed, I think it's definitely an offset there. So in terms of covering the over-the-counter, it's not going to be as significant, or actually might be a little bit of a savings as a result. In terms of the cost sharing for like covering COVID services beyond just over-the-counter tests, there is definitely a little bit of a cost for the cost sharing, currently covering it full. So if you start to charge it to the out-of-pocket amounts, there would be an applied cost sharing. There's going to be a little bit of savings, but it's not. We're talking maybe like 0.2 of a point. So it's not going to be a significant cost as a result of or cost savings as a result of applying cost sharing for the COVID services.
Okay, thank you for that. And then I know we've got some public health folks on our board. Any thoughts, since this is the first time this is coming up, for continued testing that is covered by the carriers? Go ahead, Dawn, please.
Good morning. As a clinician and acknowledging the trajectory of COVID and how many tests you do and don't need, as we are all starting to ease our way back into, I say we are all, some of us are beginning to ease our way back into physical spaces with other people and putting ourselves at risk for upper respiratory infections of a variety of sorts, one of which I am exhibiting and not sharing with you today because the remote access to these tests and to vaccines and the rest of the care is important. But I think we have transitioned in great measure to a place where cost sharing it's transitioning into a place where it's more standard care and less emergent care that's related to some of the other decisions that are happening at the state and federal level. And so whether it's covered in full or with cost share is less important to me at this point in the trajectory of the pandemic, just that the care is available, and typically one doesn't need more than 8 tests. Typically one doesn't need 8 tests per month. It's much fewer than that.
Thanks, Dawn. Any other comments on this? So my understanding is if this stands as it is, the Providence plans will continue to offer the over-the-counter tests, no cost share, and it will just be different than what the other plans are currently doing. Unless we make a vote to say we want. Go ahead, Andrew. Go ahead and clarify.
No, you're right, Siobhan. I didn't mean to interrupt you. You're exactly right where you're going. Unless you vote to say we prefer to prioritize parity across the carriers, and so we don't want the over-the-counter covered in full under Providence.
Okay, so if we do not vote on this, oh, go ahead, Dawn.
Sorry, am I missing an equity issue that we need to pay closer attention to? That there are some people for whom this matters more, that those people are likely to be people in highly impacted communities, that we need to make sure that there's no cost sharing and disproportionately impacting those communities. That's the equity issue that I'm trying to work with. I don't think it's a huge equity issue, but it might be one, and I just want to put that out there for consideration.
Yeah, and I would say that, I mean, I know that with, there are many members who make less money, they tend to choose the low-cost plans. And so if there's a difference between the low-cost plans, there's many things to consider, but we may want to think about parity across the low-cost plans. That's a big discussion too. What at the end of the day is going to end up being the low-cost plans. Kaiser, Deductible, MODA, and Providence have been very close in cost the last few cycles, depending on how we land. This time around with the renewals, we may see a plan or to not be low-cost plans, depending on the decisions that are made. And there is a comment in the chat from the MODA, someone from Erica, about MODA is able to support waiving cost sharings for the tests. And I think the only difference here is if Kaiser does it, they would need to do it for all of the parts of the testing, not just the test, but also the treatment. And it's really just the treatment and the vaccines, I guess, would have to be covered in full is what they're telling us.
So the one comment I'll make, and I should have said this at the outset, is that the vaccines will be covered in full across all the carriers. So that vaccine is on the ACA preventive drug list at this point. And so there's no decision to be made there, but you're right about the treatment. Yeah.
Okay. So any other comments? And then my question is, do we have a motion around this? Or someone can make a comment. I mean, sorry, someone could also make a comment and then we could have a discussion after the motion as well, if it gets seconded. Kimberly, go ahead.
I would just like to make a motion to accept this as presented. I think that we've had some good discussion. I think we can accept this as presented.
And I just want to clarify, Kimberly, when you're saying as presented, do you mean to continue covering over-the-counter tests in full for all the plans, or just what's on the slide and it's only covered
just
in
what's
full
on
for
the slide, because obviously there is the one difference where Providence says it'll be covered in full. The testing, the others are saying not covered. But again, I'm just making that motion, and if it doesn't get seconded, it doesn't get seconded.
I just wanted to clarify. So the motion is to have the plans cover as presented on the slide. Do I have a second on that? I don't. Oh, go ahead, Kate.
This is Kate. So I'm willing to second, but I'm also, if there's an interest in doing what was also discussed, I'd love to hear more. I kind of want to know where some of the board members are if there's concern around. I'm happy to second, but I'm also open to further conversation. I'm just gonna put that way. So maybe I will second and then make a comment and say that I'm open to further conversation if there's other kind of what's the other option that we would be as a board would want to do.
Yeah, and we can, so you've seconded it. We can have a discussion. We can also amend the motion. So that's what we can do if we decide we want to amend the motion, have a second. So any further comments?
This is
Greg,
Greg.
go ahead.
I like Kim. I have like a drawer full of these tests. And I think a lot of people do, and they are not hard to obtain. Maybe after this goes away, you know, it's something that we don't know what the cost or where these tests are going to go after. You know, if we had an idea, you know, are they going to go up to $100 a piece after this is all over? And, you know, the companies that are making them try to make another dollar out of them, I don't know. But at this point, I don't know if there's a need to have them covered, not covered, because they're like water right now. So that's just my thought. I don't know how many people actually have them. I know a lot of people I know have several of these just sitting around.
Can you restate the motion that's on the floor right now?
Yes, sure, Sean. So, so Kimberly made a motion that we essentially go with what the carriers presented, which is what is on the slide. So the costs would be covered for the Providence plans. For the over-the-counter test, they would not be covered for Motor or Kaiser. And then Kate seconded that. So that's the motion that's on the floor. And we're continuing to discuss it. Do you have any comments?
Yeah, I mean, I don't know if I have strong
ahead.
opinions on this one, given they do seem somewhat available at this point, that there would be some differences between the different plans, it seems, with this, a little, yeah. So I guess that's fine.
This is great. Mercer, do we have an idea if there's any other over-the-counter, and this is over-the-counter, do we have any idea if there's any other over-the-counter medications or types of things that are different in the plans? I know that's something you probably didn't come prepared with, but
I'll say I'm not aware of any, but would welcome comments from others.
And Don, I know you were planning to chime in again as well.
My request was to have the short version of the summary. I'm a little uncertain here because the motion that has been offered is not in alignment with the recommendation, and I would like to hear a short version from Mercer about, you know, that there's been a good deal of discussion about this, but with the levers, what the implication might be with the lever would we need to come up with money to cover those for Kaiser, or if this is a best and final, then do we expect this kind of thing to invite people to leave their Kaiser plan because they're not covering the things that people want? What would be the implications of this versus the recommendation that you've offered?
So did I hear the question? I think I got the gist of the question, Don. I don't see or foresee a lot of migration amongst the plans related to this coverage, specifically over the counter testing coverage. Let me know if I missed your question, but I see Sapari made a comment in the chat. Let's see. And I will say too, when we consider this from a health equity perspective, because these over-the-counter tests are so inexpensive today, we didn't think it presented a huge barrier if the board opts not to cover over-the-counter tests in full. But it's not zero, right? I mean, there is still a cost for those tests.
I mean, the comment that I would make around that is, we do have folks who do not make a lot of money, and they may make decisions not to get over-the-counter tests if they have to pay in full for them. And so I see it more as like, do we think that has larger public health implications here so that we should be covering them? And I'm hearing, Dawn, what you were saying, I was hearing you say no. Like in terms of where we are in the pandemic. So please correct me if I'm wrong, Dawn, on that.
I don't think it does have an equity implication, and I was trying to suss out how much that is. It's hard for me to say that I don't want people to have access to free testing. I think that's the lever, the power that we put in the hands of people to make decisions based on whether they're COVID positive. And so this is a swing around the issue from where I first came out speaking. Sorry for that confusing element. If we were to take the Mercer recommendation as opposed to the one that Kimberly has offered, how would that, the motion has been filed now, it's been seconded. We're in a place to vote on that, and it would not be to take the Mercer recommendation. Am I right?
That's right. We could amend the motion. I mean, that's also an option, or we could just start over if the motion gets voted down. So we have two ways we could go. I don't want to get us too stuck in process on Robert's rules. I just want to make sure we vote for what the majority wants.
Others?
And I don't know if this helps, but I did look up the price at Safeway. They're $11.99 for a test.
For what it's worth, we at Mercer, we did survey some of our other plan sponsors, and the majority were not covering over-the-counter tests in full. But there were some that were. So take that for what it's worth. But.
I mean, the other thing I just want to offer here as part of the discussion, we could make a decision to cover them this year. It would be plan year 2024 and then make a different decision for 2025. If, right. I mean, so we could also go that route and say, we're seeing how it goes as we continue to move out of the pandemic. Per Emory, what you're saying is the cost should be negligible. I mean, it's not going to impact the premiums for the plans.
No, I wouldn't make an explicit adjustment to the premiums if you did decide to cover the tests in full. The equity issue is an interesting one. You do have a lot of employees who are public facing, right? The people at the DMV, the other people, who are out in the public all the time, and whether there may be an additional benefit for them to just do the over-the-counter versus I'm starting to feel sick, I want to go into the doctor and have a test. So there may be that benefit as well, but it's not going to impact the composite rate.
All right. So
well, can I just follow up on that? I mean, I was understanding a couple of minutes ago that that's true what you just said, Emory, except for Kaiser, because they're not,
Yes.
They're just like, it's not an option. They're just being like inflexible. You have to do like 1,000 things or one thing, but we can't do one thing.
Yes.
So they're basically making it impossible to accept your recommendation. That's what I'm hearing you say, because they're being inflexible.
Yes, that's the current case.
Okay, so
and I think there was
that is why I'm like,
Yeah.
okay, well then I guess that's that, isn't it? So that unless that's changing, I don't know where to go from here.
Yeah, so actually, I think Jennifer Stacy would like to potentially make a comment. So, and she's from Kaiser. So.
Yeah, so thank you. I know this is an interesting discussion and that there's a lot of ways to look at it. when the public health emergency came on and many things were rolling through, all of the different requirements, you may recall, were sometimes retroactive, were sometimes forward-looking, et cetera. It's a matter of our systems being set up to support the public health emergency, and being able to untangle that. So it's not simply that we're trying to be intransigent or difficult to work with, but at this point, because of the expectation from the federal government and the unwinding of the public health emergency, we just aren't able to pick and choose from that. That's the issue that we're working with. We do understand that it is market standard to cover under the plan the condition of COVID like other conditions, which is stated in the column there, and it's consistent with others in the market. So just wanted to make that comment. It is it's a full-on roll-up of the systems and the work we did to comply with the public health emergency and then the takedown. So thank you for the consideration.
Yeah, and my understanding too, from what Emery commented, was that the treatment then would also not be at the applicable plan cost sharing, but that together that still wouldn't elevate the premium, correct?
No, that would be
Kaiser,
incorrect because of the treatment would have to be.
So for Kaiser, so for the treatment portion, there is a little bit of a cost for that. So I think, if you're going to, so for the over-the-counter tests, there's going to be no real cost impact to the premiums. All this is excluding Kaiser. But if we talk about treatment for MODA and Providence and Kaiser as well, there is going to be a little bit of a cost impact for that. It's not going to be significant for MODA and Providence. We have not asked Kaiser for that rate impact. We would have to go back and see what that rate impact would be for Kaiser.
Okay, thanks, Emery. So I'm going to move us to a vote. All right, and let me go back to my sheet so I don't miss anyone. Dawn, I'm going to call on you first. How do you vote? And I'll restate the motion. It is what is on this slide. So it's not taking Mercer's recommendation. The test would only be covered for Providence, not for MODA or Kaiser. That's what the motion is, and that's what was seconded. And Dawn, are you still here? I'm going to circle back. Oh, go ahead.
I'm here, and I will abstain at the moment.
Okay. Greg, how do you vote?
I vote aye.
Okay. Chicky?
Good morning. I vote aye as well.
Okay. Thank you. Andy?
Approve.
Okay. And Kimberly, I have you as putting the motion forward, so you're a yes. Kate, I had you second. You're still a yes. Sean, how do you vote?
Approve.
Okay. Thank you, Sean. So the motion passes with one abstention. All right. Thanks, everyone. Let's move to the medical renewals.
Ready. So, Sally, I think we're going to pass it over to you to go over the proposed ASO fees and then some of the program components as well.
Yes. Good morning, everybody. So the rest of these slides are going to look familiar. We've reviewed them in prior meetings, and we've updated them where there were updates to reflect. So this first one is the administrative fees for the two self-funded plans, and Providence did not make any adjustment to their administrative fees, but MODA did. And so you'll see that MODA has come down slightly on their fee. They were an increase of 2.9%. They're now down to 1.7. And so the fees that did get reduced were the first three: the medical admin, the utilization review, and the disease management. And so it's a reduction of almost $1 per employee per month, 97 cents. And so, Rose, next slide. And so the next slides will go through the considerations and plan enhancements we reviewed in the past. The first one is the massage therapy benefit. And just as a brief review, the recommendation was on the statewide plan to add a massage therapy benefit that matches the choice plan in order to create some parity between the plans. It comes with a cost. We estimate about 3.4 million, which could be reduced slightly if there's some medical necessity provisions introduced. And we're recommending accepting this because it is an enhancement and it helps move the needle a bit on the low-cost plan issue that we discussed earlier. Now, I don't know how we do this. So these are all for board decisions. Should I go through them? Do we do more? Should we have a vote per? I'm sorry, Siobhan.
Yeah, so we can choose how we do it. I actually think we need to have a longer conversation around the anti-obesity medication exclusion because that's something that's going to go across all of the plans. And I know we started that discussion last time. So I actually am open to going piece by piece, but having the longer discussion around the anti-obesity. Or maybe we can, if folks are open to this, if board members, we could do a vote for Providence on all of the recommendations except for the anti-obesity, so we can have that since that's something that carries across all plans. Are
And
folks
that was
good
kind
with?
of our plan, Siobhan, was to
Okay.
like, well, because when we get to the obesity, we've got some additional information to share. So we were going to try to go through the first three here, and then we'd go into the anti-obesity, which would also then
Okay.
reflect onto the MODA as well. So
Okay,
So
well,
should
that
I-
makes
should we-
sense. What, can you do the first three and then the last two? Because we also have add prescription savings solutions and eliminate
Mhm.
sexual dysfunction medication, so that we go through all of those and then go back to the obesity?
Sure,
Okay.
you bet.
thank you.
Okay. Okay, so so we talked about the massage therapy. The next one was the referral requirement under the Providence Choice Plan. So Providence is recommending eliminating that referral requirement. It's really to streamline processes to eliminate some unnecessary administrative burden for both the health plan and for the medical homes. And we're recommending accepting that one. And then the final one on this page is the EviCore physical therapy prior authorization. This is their utilization management. This is something that was introduced prior. Providence decided not to implement at that time, and they're reintroducing now. And so essentially what it would do is allow members up to 12 PT visits without authorization. And at that point, if they wanted to continue, they'd need to get authorization. The average number of, I think one question that came up in prior meetings was how many people actually exhaust that 12 visit limit. The average is about 9, a little over 9 visits for PT. So most people are going to come below that anyway. So there's going to be minimal impact to the members, but at least we expect minimal impact. And there is a cost savings of a little over $1 million that estimated, and we're recommending to accept, because another aspect of this is also just to make sure there's parity across all the utilization requirements to keep the plan in compliance with mental health parity as well. So those are the first 2, 3. Any questions before we go to the next slide? Or we have to go a couple slides actually. So if we go to the next one, Rose, there we go.
Looks like we
So
do have a question. from
Kate has a
Sally.
question.
Oh, okay, I'm sorry. I didn't see your hand. Hi.
Well, it took me a bit to find the hand, so it's probably not you, it's me. Thanks, Sally. Just really quick, on the first one with adding the massage therapy, I just want to make sure I understand the recommendation is the reason to add it is for the parity, but also it looks like your note here says it would increase the cost, which would help with the, like, so basically say it increases the statewide cost in order to allow other plans to be more than 10%. Is that what you're trying to get to on that note, on that top one?
I think that's in
Benefit
essence
enhancement, and also,
yeah,
that what you're
it gets a little more movement there in terms of the math around the low cost plan.
okay, so basically,
But
yeah,
yes.
so
Everyone.
okay.
Yeah, sorry, Kate. It does,
just feels
it does increase the
just gonna
statewide rate.
say-
Go ahead.
Okay. I was just gonna say, it feels weird that we're trying to like increase the rate, like that would be a basis of a recommendation, is to increase the rate. Now, I understand completely the benefit enhancement and parity between plans, but I do want to just note that just seems like a weird thing to do, is to say one of the reasons why we should do this is to bump up the cost of a higher cost plan in order to make the lower cost plan look comparatively lower. So I just want to say that on the record, but I do understand the need for some parity on in benefits across plans. Just note that I kind of felt weird to see that on the slide.
Yeah, so I mean, that is something that's going to help, to help create that differential between the statewide and some of the other plans. You do have a little bit of money to, that you're coming in under the 3.4%. So there is a little bit of room there. And if you do apply some of the other plan savings like the Evicor and RX savings solutions, that's going to also bring down the cost, offset some of that cost. So it's you're moving one way and moving it the other way.
I just want to recognize your comments, Kate. And in the last meeting when we discussed the changes, I know we also just discussed it from the point of view of both enhancing the plan. It's just what the other pieces that you said around giving people access to the benefit where they haven't had access. We also brought that this is a factor in recruitment and retention as well, and parity across the plan. So wanted to name those pieces because they're not necessarily lined out in here, but that was part of last month's discussion.
Okay, so Rose, could you move like a couple of slides forward, please? Here we go. So the last two Providence considerations are for the RX Savings Solutions program. And this is the voluntary program where essentially Providence will review claims after they come in. If they see an opportunity for someone to save money by making a change in their prescription, say maybe the day's supply or the drug or even the pharmacy, they will reach out to the member and offer them that opportunity, but it's totally voluntary. In the end, the program is an opportunity for the member to save money, but also the plan would save money as well. And we show some savings here for estimated savings for year one after 24 months and 36 months. Should comment that there is a program fee of 85 cents per employee per month. So that first year estimate if the savings are as estimated by Providence, would be maybe 750,000 net of that fee. And so this is something that we are recommending because it would result in savings. And then the final one is the sexual dysfunction medication. And this is one where there's low cost drugs available. There's multiple uses for the drugs. Oh, and there's a hand, so I'll stop.
We have Greg and then Sean.
Okay.
Question on the fee, is that per member who uses it or per every member pays 85?
It's every member.
Okay, thank you.
So it's a per employee per month fee.
Go ahead, Sean.
Well, follow up on that. Why is there a fee? Because this feels like standard, like kind of what we're paying them for, which is like managed care. So it's like, if it saves money, then why is there a fee? Like it's kind of like if you're managing care, and part of managing care is finding the best cost for prescriptions. That seems like kind of what they're doing, like their job. So can you help explain like why there would be an extra fee for what they're doing that we're paying them to do?
Well, sure. Well, there's additional administration that comes with this program. So both on the health plan side, and then they're also using a third-party vendor to support the process. So that's why there'd be an additional fee. So they're adding on a process that they don't currently do.
Yeah, so I hear that. And they're managed care. Like that's part of the deal. And so if like how they go about doing that is their business, as far as like whether they need to buy a vendor or if they just integrate it into themselves. Like I'm assuming that every year they're evaluating what they're doing and trying to find out ways to do it better. That's what I expect. So every time they do something new, we don't need to be charged for it, is what I'm saying. So help me understand like why there's an additional fee every time they change something.
Well, I don't know if Emery, you want to, do you have a?
Well,
more
I mean,
to
that,
add to
Sean, yeah, so Sean, I guess to your question, I mean, I guess you're asking, it's like, you know, are they doing all the right things for the administrative fees that they're purchasing? And you know, that's a really good question. You know, and we can go back to Providence on it. You know, in particular to this solution, it is a third party vendor who like has their own proprietary database, you know, systems and stuff like that. So there's an additional charge for it. Hopefully, you know, you do see the savings for it. You know, I think we can go back to Providence and say, you know, or all the plans really, and say, are you managing the pharmacy as tightly as you can? And but that, you know, that's a very interesting discussion to have. Yes, Andrew.
Okay, I turned my hand off too there. The other thing that probably warrants discussion is that with programs like this, there's typically, when a plan sponsor contracts direct with a third party like RX Saving Solutions, there's ROI guarantees. And so that's something that, you know, if the board votes on this to move forward, that's something that we would want to talk with. You know, this is Providence subcontracting with the vendor, right? So it's a little bit of a different animal in terms of what that looks like, but we would want to talk with Providence to make sure that whatever ROI guarantees they have in place would apply to PEB and any results.
Yeah, exactly. So like if we're being asked to pay their bill for a third party vendor, which they may use for other members as well, then that means that we're going to get up in their business about the contract. So it's like you can't have it both ways. So like, okay, then I want to see what the performance guarantees are, and like do we get that guaranteed then back into our contract as opposed to other contracts, and so on. So it's like you can't have it both ways. So if we're being charged the fee for the third party vendor, then we get the benefits of the third party vendor. So I have more questions about the third party if we're going to be charged the costs of basically doing part of the managed care.
So I do think that this is something, I know prescription drugs is something we need to have a longer discussion as a board around. And my understanding from our overall timeline, which has been shared in previous meetings, we can have that broader discussion in July. I know that what's before us right now is making the decision around whether we move forward with the program. Is there anything you want to add on that, Ollie, that I may be missing around the board discussions?
No, I think you covered it, Siobhan.
And then Greg, did you have another comment? Your hand's still up.
Oh, sorry. I can't see if it's up. Yes,
Okay, no worries. So I think at this point, I'm looking to see if we have a motion to move forward on the Mercer recommendations around the massage therapy benefit. We're bundling these unless there's a motion not to, but the massage therapy benefit, eliminating the referral requirement for specialist care, adding EviCore, and then the two that are still showing up on the screen, adding the prescription savings solutions program and eliminating the sexual dysfunction medication exclusion. So do I have a motion around those?
My only question before that is, this would be to add these, not to approve them 100% today, correct? Or are we approving them to move forward?
We would be approving them to add them to the plan, yes, the Providence plans.
Okay, so the questions we have on the RX savings plan, we basically were going ahead and do that, but questions that we're asking today wouldn't matter because we're approving that for the 24 plan. That's what I'm understanding. Correct?
Yeah, and my understanding, and this is something I think Ollie can provide clarification on, is that how plans work, because this is a self-funded plan, Providence is, like the questions that Sean is raising, we can have a deeper discussion about that as a board in July and get further information on that. Is that, and I just want to verify that that's true.
Yeah, I mean, it's probably worth mentioning or just reminding the board that the PEB, the Providence plans and the Moto plans are self-insured, so they're really your plans, they're really PEB's plans, and Kaiser is a fully insured, their plans are fully insured, so a little less flexibility maybe. So I think that, you know, when you make some of these decisions, you know, it's probably something to keep in mind when we look at, you know, how we structure incentives to drive behavior amongst our members.
Can I ask a question too, Ali? Is it, in the past, have there been contingent approvals? Like, could the RX piece be approved now contingent on the performance guarantee around ROI, which would give us time to work with Providence in the next month and then present that in May and say, yes, you know, here's what they look like, or no, or whatever those details are? Is that something that's been done in the past?
Yeah. Yeah, I think that's totally fine.
Or the reason I was asking, I was looking to make a motion to just pull, as we were going to the obesity and that one, okay, everything else with the same, basically the same type of deal where you got to look at the obesity to get a little more into it. And you guys could look into this a little bit and we could then vote to approve them at the next meeting. If so, that would be my motion. If not, we can do something else.
I would second that motion.
Okay, so we have a motion on the floor to add the massage therapy benefit, eliminate referral requirement for specialists, add EviCore, and eliminate the sexual dysfunction medication. Motion made by Greg, seconded by Andy. So I'm going to take a vote on that. Dawn, how do you vote? And just let me know if you need me to restate the motion.
Aye.
Okay. You're voting yes, aye. It says you're, okay, great, thank you. Chicky?
I vote yes, please.
Thanks, Chicky. Kimberly?
Yes.
Kate?
Yes.
Sean?
Approved.
I'm sorry, I didn't hear you.
Approved.
Approved, thanks. Okay, I believe that's everyone, so the motion passes. And so should we go to the anti-obesity medication discussion now, or should we discuss the other plans first and then talk about them as a whole? I'm open. Maybe I don't see anyone raising their hand. Why don't we just go ahead and move into the anti-obesity medication discussion?
Okay, so previous slide, Rose, please. So go ahead, Emery.
Yeah, so actually, okay, so you can see down here in the bottom page 16, you know, we've had a little bit of discussion on anti-obesity medication. You know, the medications, they require so the GLP-1 drugs, which are for the diabetes, can also help reduce weight. There's different formulations for the weight loss drugs or different strengths that end up being classified as weight loss drugs, and those weight loss drugs are excluded. But so some people are potentially using these diabetes drugs. Maybe they do have diabetes, but it also has the added benefit of helping them lose weight. And so some members have asked about having the weight loss drugs no longer be excluded, and to help them lose weight, which would be an additional cost. You can see that, based on, we do project that if you do remove the exclusion for anti-obesity, there is a cost. In this case, it's about $2.5 million for Providence, and we can go over some of the cost benefits in at least on the next slide as well. But if we actually move on to the next slide, we can show you the usage, some data around usage of these GLP-1 drugs, as well as taking a look at those who have type 2 diabetes. because type 2 diabetes is the indication for getting access to these GLP-1 drugs. And so these drugs include Ozempic, which has been in the news a lot recently and, on social media as, people potentially using those off-label just to lose weight. And so what we wanted to do was take a look back at the claims for PEBB to see if people are potentially maybe getting access to these drugs to lose weight, and the cost of the drugs, as well as, comparison to the cost of the treatment for diabetes as well as obesity. So based on the PEBB database, what we saw was over the past 3 years, about 2,346 members have utilized the GLP-1 drugs. So there's about $28.8 million for those 2,300 members. And so that works out about, actually it's not PMPY, but that works out about to $12,000 per member in this case. So $12,000 per member for these drugs. There are approximately 8,800 members there on the left-hand side with T2D, which is type 2 diabetes. So the indication for those drugs. So about maybe a quarter of the members who receive GLP-1 drugs have type 2 diabetes. So the cost of the drugs for those who have type 2 diabetes is about $13,000. So that's pretty significant. Their medical cost was about $3,000. The drugs for diabetes tends to be the bigger portion of the cost. So that's not too surprising, but the cost of these GLP-1 drugs is definitely higher than what the typical pharmacy cost for diabetes is. So the typical pharmacy cost for diabetes is about $7,700 there on the left. So the GLP-1 drugs are more expensive at almost double that price. Of those members who have type 2 diabetes, about another 195 had a diagnosis of obesity. And so what we wanted to do was take a look at those who have type 2 diabetes, in terms of the cost of the drugs versus the cost of the treatment for the obesity. So the drugs cost about $13,000 and the obesity costs are about $6,000. So you can see that the GLP-1 drugs are more expensive than the medical cost of diabetes, which indicates, maybe it's not, while they do help you lose weight, the cost of the drugs is much more significant than potentially the medical cost of treating diabetes. So that's, so in terms of the weight loss drugs, the GLP-1s do help, but, it may not be that additional savings from lower medical costs in this case, because it does have a higher cost than the obesity treatments. And the Wegovy drugs, which is the version that is indicated that's approved for weight loss, is actually more expensive than Ozempic, which is for diabetes. And so, the additional cost for the weight loss drugs would actually be a little bit more significant in this case. Sean, actually, I think I saw your hand first. You had the question?
Yeah. So this is helpful. Thank you. The last, I think we talked about it, and John, I don't know, I'm kind of looking to see if you might have some thoughts here from a clinical perspective, but I think one idea was that we were talking about I don't know if you want to call it a pilot, but like a starting point of folks that have a BMI over, I think we were saying 40, if I remember right. It's like whatever the BMI is that basically puts you into the category of potentially having surgery, like and theoretically this is less of a intense intervention than surgery. And so maybe that would be like an appropriate place to start and just kind of see what happens with that group as far as costs and benefits and so on, because they're already in the consideration for surgery, so which is like already kind of. So anyway, I'm just kind of refloating that concept. But I don't know if there's other perspectives broader than that. I don't know.
Yeah. So, in terms of the data. We do have some information about BMI. We don't have complete information, so we haven't been able to identify exactly where people fall on that BMI index in our data analysis. But there are definitely different types of programs or different types of criteria that you can apply for these weight loss drugs, whether it's the BMI or being participation in the weight loss program. I think it's not just getting the weight off, it's keeping it off. And so, whatever PEBB can do to help that in that process would make the benefits more efficacious in this case of approving the weight loss drugs. But generally, I think there are definitely portions of people who are getting this. A lot of them do have the type 2 diabetes, but there are a few that don't have diabetes or obesity, and they're getting this drug. So, there are part off on this, but some of them may be using it off label in this case. But Dr. Troy, you had a comment?
Yeah, let me add some clinical color commentary. So historically, obesity is undercoded within claims. So epidemiologically, we know that up to half of type 2 diabetes are due to obesity progressing and becoming the type 2 diabetes mellitus. So we could sort of use that as sort of a corridor to anticipate the pattern. And a couple of things related to the correlation with obesity and type 2 diabetes, and why it's worthwhile talking about the two, because of the both the progression from obesity to diabetes, number one, and then two, the presence of obesity amongst the type 2 diabetes complicates and accelerates the cardiometabolic disease progression. So it is true that the attributable diabetic medical cost at a snapshot in time may be low relative to GLP-1, but what we're trying to improve is both the improvement in weight with GLP-1s as well as the hemoglobin A1C. And good research study has shown that over a 5 to 6 year time frame, we can slow down, if not stop, the progression or onset of the cardiovascular diseases that are really the higher cost. So this is about cost benefit over time, clinically leading to the financial. The other dilemma is the progression of obesity to type 2 diabetes can happen similarly within a 5-year timeline. And I think your point about the criteria for high-risk obesity that makes it, based on clinical guidelines, efficacious to consider bariatric as well as GLP medications is also overlapping with the same risk group if you're type 2 diabetes with obesity. So if you think about it that way as two Venn diagrams, if we're thinking about whether to exclude the treatment of obesity, you can think that some of them will be treated as diabetes as a primary, with obesity as a risk factor. Anyways, so that's one subset. The other ones are the severe obesity that do not have type 2 diabetes that may end up sort of missing that coverage from an obesity perspective, but they may meet the bariatric criteria. So they may be only limited to that surgical option given their severity indication. So those are some of the factors to weigh in there, the consideration.
Sean, you had the follow-up?
Yeah, so follow-up question on Mercer's recommendation. I think I saw in the recommendation for this in general that there was this attachment to an expectation to, I don't know, connecting people to lifestyle change services or what have you. Can you tell us a little more about that? I mean, is that like an additional program? Is there like an additional fee for that? Is that an existing program that we've already paid for? Like, do we have a particular one in mind? Are we talking about tying continued prescription use to that? Like, can you give some more details? Like, what does that look like?
Emery, do you want me to weigh in on that?
Yeah, you can weigh on it. And I think, Andrew, did you want to weigh on it as well afterwards?
Sure. Yeah, go ahead, Dr. Trank.
So from a medical perspective, absolutely. These medications are very effective. They reset both the diabetes as well as the weight points, as well as start that physiological improvement. So what we do know is, sorry, lost my train of thought. So your question was that oh yes, the lifestyle. So for obesity, the medications alone, if nothing else changes, there is a need to perpetuate the medication because none of the drivers of obesity changed. But what we do know from good studies is when you supplement and coordinate the medication with intensive intervention, that there's a percentage of individuals that actually their own lifestyle and behavioral changes can carry this and sustain the improvement. So a program, for example, I think you have Verda in place. One of their objectives is to sort of deprescribe once the patient is both stable at that improved set point, as well as they're taking their actions and sustaining them in a meaningful and reliable way, then it is worthwhile to try them off the medication. So that's the tremendous value of combining the two. All else, the risk is they're relying on the medication to basically maintain that improvement, and nothing changes, and hence the medications don't go away.
And that,
So
yeah.
And this is true for obesity and diabetes. I just want to clarify the dynamics is the same.
yeah, Dawn raised her hand and I just wanted to invite her to weigh in on this.
Thank you. It's a pretty important and rich conversation. And this is a debate that's happening, of course, at every level across the country. The fact is that there's now medications that can help people lose weight. We have some somewhat longitudinal data, but not very longitudinal data yet. So we don't have an idea. We don't have data to describe the long-term impact. And I think that most of the data that we have are for around 12 months. So there's some, I think, that's further than that. But it does help people. It does help people lose weight. It does help control diabetes. It can impact some of those cardiovascular outcomes. All of those things in the short to medium short term, at least, and not a ton of data either on safety or efficacy for the longer term. We do know that it is quite expensive in this upfront time frame, and if the question that we are trying to ask is a cost effectiveness question, then I don't think we have good data about that, because if there is long-term savings as a result of improvement in health, then we don't know it yet, not very much. However, there's reason to believe that that might be the case. And if we step back from the cost effectiveness question and just look at the safety and efficacy questions, which are, I think, appropriately the first round of consideration, then we see effectiveness in the short to medium term in terms of weight loss, and effectiveness in the short and medium term in the way of diabetes and potentially cardiovascular implications. None of that answers the question, should we cover for people for obesity who don't have diabetes or other comorbidities or other conditions that are high-risk conditions that are associated with diabetes, such as hypertension, high blood pressure, and cardiovascular disease. And I don't have a simple packaged answer to that, but I wanted to share that much of my clinical awareness in support of what our other clinician here has has just been saying. So thank you for that review. I also can contextualize a little bit the Health Evidence Review Commission and the Drug Effectiveness Review Panel, I think they're called. Those organizations and the Pharmacy and Therapeutics Committee are conducting a review of these drugs for the treatment of obesity that should be available this fall. It is not currently available, but it's on everybody's mind.
Go ahead, Kimberly.
I would just add, DOC does we're working so hard on wellness and staff. And because our jobs a lot of times are sedentary in corrections, you know, you're a housing unit officer or you don't get much, your biggest walk is going to and from the housing unit or to and from your office. And plus our state workers, probably a lot of that is true for a lot of us. I think any help that you give somebody to kind of start down the weight loss path is helpful. And so again, I love that there is data, not enough yet, but I love that we at least are talking about this because I think it is important to not just recognize those folks with type 2 diabetes, but those folks that really at the end of the day, we know if the weight continues to rise, diabetes is not far behind, or heart disease is not far behind. I don't know if any of us really need data to tell us that those two are not far behind with the weight gain. So that's all I have.
Sean, you're going to comment again?
Well, so to summarize what I'm hearing, there doesn't seem to be like evidence already existing that this is a clear return on investment from just the dollars and cents point of view, as far as I understand. That being said, the question I think then becomes quality of life, which, I mean, there's a lot of things we pay for that improve quality of life that don't have a return on investment. So it's like good to know. Okay. So it's a cost. The quality of life question seems to me to have like enough information. Like I hear, Dawn, like the Health Evidence Review Committee hasn't decided, you know, for sure right now, but it seems to me like if you're pre-diabetic and this helps to delay the onset of diabetes for some amount of time, that's pretty clear benefits quality of life, because it's not just that diabetes costs money. It's a knock to quality of life. You know, your eyes worsen, you know, potentially down the road, amputations, you know, heart disease and so on. So, you know, so there might be something to be said for just like this could help delay a terrible disease. That being said, it does look like it's a cost. So I'm just, but you know, I guess that's just kind of my summary. I mean, it's like, I don't know if we're in a position to spend more right now, but there is something to be said for quality of life improvement without it having a necessarily automatic return on investment. So that's it.
Appreciate folks' comments. I actually have a question around the recommendation, and I see the recommendation both for Providence and for MOTA around this. My question is this, is the recommendation that it would still be clinically approved, but it would just be pretty much wide open in terms of the approval for the drugs for weight loss? Or is there any kind of like medium space? I feel like when we discussed it last month, there was a criteria, like if you were eligible for bariatric surgery, then maybe you should also be eligible for the weight loss drugs. Or is there any in between versus what's in front of us to approve?
So, Andrew, feel free to chime in, but yes, definitely, there is definitely in between that could be done in terms of the criteria for the weight loss, the eligibility for the weight loss drugs, as well as, you know, potentially having a third-party vendor help or the plans much more strictly manage and ensuring that the weight loss is happening and that there is potential, member behavior changes going on with those, with the weight loss to ensure the long-term improvements in the health and lifestyle as well. So I mean, we can definitely I don't know, Andrew. I mean, maybe we need to go back.
Yeah.
Go ahead.
One strategy. So I think there's a couple of strategies that we might have floated when we met last month, or maybe even the month before. One is to introduce really strict prior auth requirements in year one. Maybe that's BMI of 40. And then in year two, evaluate the efficacy, from a health outcomes perspective, as well as the member satisfaction perspective and everything else, and perhaps walk that back in year two and sort of stage it down to 35, BMI of 35. Yeah, go ahead, Sean.
So can I just propose that that we table this till the next meeting? Like I would like a little detail. It seems a little like, because the original Mercer recommendation, as I recall, was like, don't do it. There's not enough information. And then we talked, and now it's like, do it all, and feels like there's like an in between, you're pre-diabetic, you're on the list for bariatric surgery. I see this mention of like, and this should be attached to a lifestyle change. It's like, what does that look like? So like maybe some detail about like, so if that's a requirement, what's that look like? And what is the limitations? Is it pre-diabetes and above, like that everyone is qualified if you meet that, or is it just like all open, or is it just if you're qualified for bariatric surgery, then you also qualify for this? Like it would be good to have those details. Just kind of like, so there, and that's the recommendation.
So,
Yeah, we can do that. All right, go ahead, Siobhan.
oh, yeah, I was gonna essentially similar to what Sean's saying. I think it would be helpful and to have the costs associated with the which direction we go, whether it's what is recommended here by Mercer attached with the lifestyle changes, going back to what you had I feel like you put it out there last month, which was the 40 BMI and maybe staging it down to 35. So just what the different options are and the costs associated. And Dawn, I don't know if you have anything else in particular that you think from a clinical perspective it would be helpful for Mercer to be asking for from the carriers if this were added.
As we spoke last time, I would welcome a conversation with Andrew or someone from Mercer. I know that I offered that last time and it got canceled, so we didn't have a chance to do that. We didn't have a chance to do that work together offline, and I will renew both my offer and my commitment to make it happen and move other things instead of letting it get canceled, so that we can have this conversation in a reasonable and thoughtful way, because for all the reasons of complexity and parsing data that is, as we've been practicing with COVID, necessarily incomplete because it's early. And it will change over time, and we'll have more information in new phases.
Appreciate
that. Yeah. I would say this sort of, and just reacting to that comment, this sort of lack of robust longitudinal outcomes data is really what informed our preliminary recommendation to defer this for a year. We have since revised that to say, if the board wants to approve this and move forward, because it's not a straightforward decision. There's more than just the cost piece, and there's the member sort of quality of life. There's also health equity considerations, which we can get into. We've got a whole review of that. So there's really a lot to parse out. And so that's really what informed our revised recommendation, where it was, if based on weighing all of those different categories, the board still wants to move forward, then we strongly recommend the lifestyle coaching piece. But what we can do is more clearly outline exactly what some of that PA requirements would be and the associated costs at different levels. And maybe next time we can unpack exactly what that lifestyle coaching looks like and provide some more specifics around that.
Appreciate that. And Greg, did you want to make another comment or question?
Yeah, the only thing I wanted to say was we're not the only ones having this discussion, as Mercer can tell you. I sit on the, well, I've been part of the CL board now, and we had this discussion just 2 weeks ago, and they are asking just as many, if not more, questions than we are on it. So it's both boards are looking at it to try to decide really what to do.
And so do you want to thank you in advance for the continued work around this so that we can make the best decision that we can at the May meeting. And so this, I think when we move, because I think we're going to talk about MODA next, let's, this would be the same for MODA and Providence, for all the plans and the anti-obesity drugs that we'll have the further discussion. So should we go ahead and move to the MODA plan considerations?
If I may,
yeah,
if
sure.
I may,
Go ahead,
as a
Dawn.
final, just as a final shot across the bow of this conversation, what is any opportunity for negotiation? The cost of these drugs is high. I know that patents are in place. I know that there are some programs in place at some of the pharmaceutical companies to make things available at lower cost. I'd like an awareness of those options in terms of impacting the cost element of that decision. Thank you.
Jennifer, did you have a comment? Okay, maybe not.
No, I don't. Thank you.
Okay, are we ready to move on then? Okay,
believe
Rose,
so.
I think we have a couple more slides to move forward to get to the MODA slides. Thank you. Rose, we're going to talk about more prescription drug, another prescription drug topic. So the Copay Max Plus program. So this is a specialty drug coupon program. So essentially what it will do is for those individuals who can benefit from a manufacturer's coupon for these specialty medications, they'd get enrolled into this program, and the plan would get the benefit of that coupon. But on the other side, the cost sharing that the member pays the actual cost sharing would accumulate to the out-of-pocket maximum, which doesn't happen currently. So there'd be some savings to the plan. We recommend accepting this. There's estimated savings about 2.4 million net of an administrative fee. We recommend this program. On the language services, we talked about this a bit. This is really about translation or interpretive services when someone's visiting the physician's office. And we did a little more research after the last meeting and have determined that really these are services that providers should be providing in their office as part of the cost of doing business, essentially. And so on that basis, and we've also determined that, like with both Kaiser and Providence, those are included without additional charge. So we have changed our recommendation to decline this service because we don't believe that it's necessary to add it because it should already be covered. And then the final one on this page is VERDA, which I think Dr. Schwang touched on, which is a program that is a diabetes reversal program through diet and some other support. You already have this on the Providence plan, and we're recommending accepting their the startup cost. There'd be a cost the first year, but it's relatively minimal, and then we'd expect to see savings in subsequent years. And this really is designed to provide some additional support to your diabetic members. So you have a diabetes management program through MODA. You've got the DPP program, and this would be another opportunity to help people who are diabetic. And then I think we're going to follow the same approach, Siobhan, I'll go to the next page. Rose, and we have some other. So we had the nutrition support and the flex funds. These were sort of new programs that MODA was piloting. One is to provide food to support healthy eating, and the other one is to provide some resources or connecting members to resources or providing them actual funds to pay for certain expenses if they can't afford to. We previously recommend declining, and we continue to recommend declining these because they're both would end up being taxable benefits. These are not a non-tax benefit. And then we already talked about the sexual dysfunction drug and the NOBC drug. So there is one more on the next page, Rose. This is MODA, which is the Behavioral Health 360 program. And this is a program to provide some additional support around behavioral health. Since our last meeting, MODA has reduced the price from $1.76 per employee per month to 88 cents per employee per month. This is a program where, I think we sort of contingently recommend, consider the board, recommend the board consider implementing. But if they were to implement, to look at maybe some stringent performance guarantees around member engagement and member outcomes. The reason for that is that this is a new program. It's somewhat unproven. We don't really have any history with it. And so we think that if you were to implement it, it'd be something to like reevaluate after the first year to see whether it's an effective program. An added comment we make about it is we did ask for, based on the conversation we had in the last meeting, to look at Spring Health, which is a network that is part of this program, and adding it as a standalone basis. We have not received the cost on that yet. We do anticipate that would be at least, we're anticipating it would not be less than the $1.76 that's been quoted on a standalone basis. So that's still outstanding. And then on the next slide, we'd outlined some of our concerns also about the program, about some of the fact that, Spring Health is only offered as a component, that the behavioral health champions in this program are not licensed, and that the platform that was part of the program is no longer available. So we have a few concerns about the program that we wanted to bring to your attention. Do you have any questions about any of these? And Andrew, I don't know if there's anything you would like to add on this particular topic, but.
No, I think you covered it. Yeah, I'd welcome questions first. Yeah, go ahead, Siobhan.
I just wonder, because I know we started this conversation at the last meeting, because and we can see if we have a motion to look at just the copay max program, the language services, to look at the recommendations Mercer made around that, VRTA, nutrition support, flex funds, and then the eliminating the sexual dysfunction medication, and then have the discussion around, we've already tabled anti-obesity, but then have the discussion as a standalone around the behavioral 360.
So moved.
Rather than, okay.
Second.
Perfect.
Okay, sounds good.
Are we all
So,
supposed to chime in aye?
well, I think that's the approach we're going to take. And so I don't know if I should also read that as, Sean, you're making the motion that we should do that. And then I think Dawn seconded it, or whether someone just wants to state the motion that we then vote on for those particular.
You were doing so great.
Okay, Sean.
I was trying to do it so I didn't have to re-summarize the
Okay,
whole thing. Okay, I'll have to go back to the
Do
slides.
you want
so
me
I
to
can see them.
summarize? I'll summarize.
Yeah, that'd be great.
Okay, so it sounds like we have a motion from Sean to take Mercer's recommendations around the Copay Max Plus program, the language services, medical and dental, the VRTA, the nutrition support, the flex funds, and eliminating the sexual dysfunction medication exclusion. I didn't catch, was it Dawn you seconded it? Or was it? Yes, okay, Dawn seconded it. So that is the motion before us that, yes, Kimberly, we can now just move to vote on that. And we're looking at Mercer's recommendations. Some of those we're accepting, others we're declining, which is all listed out on the slides. So Dawn, since you seconded it, you're a yes. Greg, how do you vote?
Yes.
Okay. Chicky. I don't know if
Yes.
Chicky's, okay, thank you. Andy.
Yes.
Thank you. Kimberly.
Yes.
Hey, Kate.
Yes.
Okay, and Sean, you moved the motion, so the motion passes. Okay, so now let's go into the discussion about the MODA 360. I don't know if someone wants to make a recommendation at this point or someone wants to ask questions around it. And it looks like there's two things in front of us, which is both considering behavioral 360 and looking potentially at Spring Health as a standalone.
I think as the program, it's not just the program itself, but as we discussed on the previous with Providence, we're looking here again at the per member. So kind of the same thing I feel would apply, that we would need to get some information on the vendor. And then of course you guys have given us some information where some of the people are not licensed. There are some things here that I'm not sure, with it being not having enough information or it being very, very new, if it's something we want to venture into right away. But as Sean was saying, adding, again, this is something that's, we've talked about or discussed that maybe should be part of the package, not us paying additional money to manage health. So I know we discussed that last time, as well as in the interim. So just my two thoughts.
Yeah, appreciate those comments, Greg. And Ali, I know this is a program that OEB adopted, and I don't know if you have any further insight you wanted to offer the board around the experience.
Yeah, I mean, I think data is not quite been in a place where it could inform decisions for the PEBB board. But if you look at the first bullet under member impact, I think it has some information on OEB on the slide, that their access and ability to access providers has been improved. But yeah, go ahead, Sean.
Well, you're not going to be surprised, I'm sure, to know what I'm going to say, but just to say it. So just looking at this first paragraph, right? Maybe I'll try to summarize it like this. This program assists members in getting connected to the care they need in a timely manner, and is working to ensure quality treatment and outcome measurements are in place through the selection of the best-in-class subcontractors. So from my point of view, that's what I thought that VODA was doing, like, is their basic job. So I need to understand, like, why is this different with a lot of data? Because that was my expectation coming into this renewal, was that that's what MODA was doing. So I'll stop there and just leave it at that.
I guess the question that I have for board members, is there something else we need to see on this before we make a decision? Or are we at a point where we think, I mean, is this pretty much the data we're going to get to make the decision around this? And so should we just have the vote on it today? Dawn, go ahead.
I find this confusing because it says Spring Health does all these amazing things, and amazing turnaround, access, all the stuff, Spring Health. We don't know about that yet. Can we talk about 360? And so I'm having trouble knowing what it looks like Spring Health is the thing that has the outcomes that are of interest, and that 360 isn't doing that, and we're being asked to approve 360 under those circumstances, which becomes null and void if we hold Sean's question. You were supposed to be doing this anyway. Why are we adding it on as something else? Thank you.
Do we maybe want to step back, and Christy, do you maybe want to provide a quick overview of the program that sort of touches on some of these questions? Or I see you had your hands raised, so maybe you were going to make a different comment, so feel free to do that as well.
No, I'm happy to do that. And so I think that, what Ollie said too is that, this is a new program. So I think a lot of the data is yet to come. But what we've seen preliminary that's been provided to us is that Spring Health is able to show quick access to care and the outcome, and that's what they do well. And they have a platform that folks can go into. They can schedule an appointment online with a provider, and they know their capacity of their providers. The behavioral health champions are kind of the front door, I would say, to this program that is more of a concierge support of helping people who maybe don't find Spring Health through the digital platform and go that direction, but want to be more telephonically talking with a champion who might help them through a situation and get them connected to the provider. Outside of Spring Health, the champions and within the MODA network, again, kind of outside of Spring Health, so maybe in-person care, trying to see somebody, and maybe some of those higher level, I would say maybe, possibly psychiatry, some of those pieces that might have a longer time to access for appointments. That's where we're coming into, like, that time to appointment is more, 10 business days, 2 weeks kind of time frame is what we've received as far as information. There are definitely a larger number of, from the OEB data, there's a larger number of members that are accessing Spring Health digitally and getting appointments. But then there is also a small, there is a group of the members as well through OEB that are talking with champions and getting connected. So it's hard right now, but Spring Health is definitely where you're getting most of your data right now. You're getting the quick access to time and you're getting the quality with outcomes.
So that just, I appreciate, Dawn, you asking for the clarification on that. And so it sounds like what we need then, or I mean, from my perspective, is that it's not the behavioral 360 that'll get us there. It's potentially Spring Health, and we don't have the data on what that cost impact would be, and if we can have it as a standalone, and maybe we'll have that in May. Is that right?
We should have it in May. Yeah, standalone. Yeah.
Dawn, did that help clarify?
It does, and I want to add in one other thing. Behavioral health access in this state is, shall we call it, challenging, and keep the language nice. And so the having a behavioral health navigator or somebody who can connect with people who don't have good digital access and provide them with that support, that navigation support, that might turn out to be a really useful and important thing for some of our members. This is an equity issue now, right? People who don't have good digital access, or either for reasons of no network in rural areas, or for reasons of literacy, digital literacy, and comfort navigating healthcare in all its complexity online. So I don't want to devalue what 360 might be able to do, at the same time as not feeling like I have all the information. I would need to make a wise decision about it today.
I guess I just wanted to add one thing, Dawn, to your comment too, is that Spring Health does have care navigators that have telephonic. We're just not clear yet if that's part of what MODA has in place, is access telephonically to their care navigators. So we can clarify that prior to the May meeting.
Thank you.
Go ahead, Greg.
And just my understanding, if we do, so, MODA BHG 60 is at the 88 cents. And then as a standalone, Spring Health would be 88 cents. So if we were to take both of them on, it would be, it would be 88 cents a piece, or are they both combined into one? I'm just trying to understand to make sure that I have it correct.
No, so that 88 cents is just MODA's offer to reduce the year one fee. And so they're not they're not saying that they would sort of decouple the behavioral health champion program with spring. It would be the same program, just a reduced fee in year one. Does that answer your question, Greg?
So it's both programs basically together.
Yeah.
And I think what we don't know, Greg, is if we were able to get Spring Health as a standalone, we don't know how much that would cost at this point because we haven't heard back from MODA on that.
Right, I understand. Yeah, if we get it
Okay.
taken out where it's just.
Okay, thanks. And Andy, did you have a comment or question?
Yes, I just want to kind of echo what Sean said. I really feel like with the Behavior 360, like those are things that MODA should already be doing, and that we're going to pay extra for them to have another vendor. And I feel like that's part of their managed care. So I just want to put out there that I'm very curious. Like I do think that that's kind of you know, within their realm, and that they should be covering that.
Thanks, Andy. Appreciate the comments and discussion around this. It sounds like we want to have further discussion if we can get more information on Spring Health as a standalone to make that decision in May. All right, so I believe we are moving to Kaiser, is that right?
That's right. Kaiser's next.
So, Siobhan, are we doing okay timing wise? I know.
So I thought we had till 11:40. Oh, no, we're at 11:30. We said we would schedule a break and we've been holding people. So why don't we go ahead and take our 10-minute break right now just to give people a chance to move around a little bit. And then we'll discuss Kaiser. So we'll take 10 minutes. We'll come back at 11:41. Thanks for doing a time check. Right, welcome back from break, everyone. Want to make sure our presenters are here. All right, looks like it. Folks are coming back on camera. And so I just also want to let folks know that we do have some flexibility in our agenda. I know that Ollie is happy to email out the legislative update and the update from the CIO committee. So it just gives us more time to have discussions around renewal as needed. So just want to let folks know that. And Sally, Andrew, Emery, who should I give it to?
I think I'm going to start and then they'll both jump in. So next is the Kaiser renewal. And as we mentioned before, their final renewal is 13.49 or 13.5%. And that's split between the HMO and the deductible plan, 14% increase on the HMO and 12.5% on the deductible plan. Trend is higher than it has been in the past. It's almost 4.5 points higher than last year, which and the additional cost attributed to that higher trend is over $15 million. The trend is not PEBB specific. It's based on Kaiser's book of business. And as a result, we have asked Kaiser for some plan options to mitigate some of this increase, which is on the next slide. So one option is to consider making some plan changes. There's one we are recommending. And then also considering not buying down the deductible plan to achieve the lower cost plan status. And before we move to the next slide, Emery or Andrew, anything you'd like to add to that?
Yeah, so, a couple things, based on the high trend there, their trend last year that they provided in the renewal last year was about 5.5 points. Now they're basically asking for 10% annual increases over the next 2 years. So essentially, the expected internal cost for Kaiser is increasing 10%, and that's the book of business, and so it's all of the Kaiser required revenue that that it's being applied there. So it's a huge increase. Most without the trend increase, the renewal would be about closer to 5%, which is much seems more in line with what you've seen from Kaiser in the past. So it is a large increase, and and a lot of the elements there are not they're very Kaiser specific rather than PEBB specific. There's not been real consideration about the pricing impacts, the Senate Bill 1067 and the 200% Medicare impacts on the trend. We did ask about that multiple times, and but they held fast on the trend rates in this case.
Thanks, Emery. And so I know we've got Kaiser folks here. Are there any comments we have from the Kaiser folks around the increase, since it is much higher than we've seen in the past?
Yeah, thank you,
Sapari.
Siobhan. Yeah, thank you. This is Sapari Sturdivant. I appreciate the opportunity to comment. I have with me today a couple of our leadership team members, Jennifer, Stacy, and Keith Forrester, to kind of help provide some comments with respect to what we're seeing today for our Oregon PEBB account with our higher renewal increase. And I know that you have not seen this from us in the past. This is definitely an unusual year. So with that, maybe Keith, can I have you comment on some of that?
Sure, be happy to, Sapari. Thanks. So, just to know, we share your desire to remain the low-cost, integrated plan. And while we do that, delivering on the triple aim, both in the short term and the long term, we want to get to that 10% threshold to remain that low-cost plan. So that is not lost on us. We want as little disruption for your members, our patients, again, in the near term and the long term. And it's more consistent with our commitment to affordability. And as you see, some of the managed plans are going up at a higher rate of increase. And so that is not lost on us. Just so you know, just a little bit of context here, this last round, so what we've just submitted was the first time it reflected our final 24 factors that we use. So the previous factors were preliminary. So we've already begun huddling now that we kind of see where this puts us in relation to the others. And we're considering different rates of increase by plan. That's called out there. So that could help us. Also, is the plan changes, that are outlined before, and also, is there a role for the reserves could play in smoothing the experience? So we're huddling already, and we're gonna continue to do that. What we're really seeking to balance, and this is not lost on you, but I'd be remiss if I didn't say it, is we're trying to balance that affordability with these real-time impacts that have hit our organization around inflation with the supply chain, pharmacy costs, escalating staff costs with labor, and increasing demands for care. So all of that is to say, we'd like to reevaluate this and come back and make the improvements that we can, realizing, the goal of the PEBB board, and make sure we're maintaining consistency with those patients and achieve that low-cost plan. So that's our ask. Jennifer, I don't know if you wanted to add more to that, or Sapari.
No, I think the timing piece is important. So understanding that we're in round 3 and round 4 we'll be looking forward to. And then just from a timing perspective, we've talked a little bit about what it looks like in the industry, why, as Emery mentioned, the trend has increased, and we did increase our trends throughout last year. This is an early renewal, as you know, on your timeline. The use, especially in Oregon, with the underbedding of the hospitals, we've seen tremendous increase in our members being outside of our hospitals and having non-members within throughout the COVID experience. We're still seeing that to some extent. It is moderating. What we're expecting, though, as we understand the impact of what was a long time coming, nursing shortages, PCP shortages that we've been preparing for, but that was accelerated through the pandemic and inflation. We think healthcare has achieved a bit of a new watermark, right? We're working through what does this look like in the current environment, and how will we as an integrated system then rebend the trend. And so we're putting a lot of work into making sure we continue to accelerate open access, increased access, that we're continuing to address that deferred care, that we are keeping qualified staff to deliver that quality care. And so I think you'll see a change. We're hitting it early. We are a contracted organization that has 2 and 3 years of contracts in place. For the most part, we are integrated and providing care in our system. So I think we're seeing what a lot of organizations are seeing right together in real time. I know you've read in the paper last week, it was Legacy, Coos Bay hospitals. So I think you've read and seen in the industry, what do healthcare delivery systems, what are they experiencing? And Kaiser Permanente is no different, except for we are set to be able to say, how do we utilize the care staff more effectively? How do we control our costs? And we'll be continued to focus on that going forward. So again, we understand this is very outside the norm for us. It's not consistent with the 5, 6, 7-year history if you look back at our renewals. So we understand the concerns, and we're focused on moving forward, as Keith mentioned, both in the short and long term to improve this.
Okay, sorry, I was trying to get off
questions?
mute.
Yeah.
So I was trying to get off mute there. I know this is unusual to have the plan speak, so I just want to give it back to Mercer, because I know that we're considering plan design changes, and if I'm hearing you correctly, Kaiser, you would also potentially bring back different rates based on the plan design changes we discussed. I just want to clarify that, because,
It could be a combination of both plan design and just a lower rate of increase. And it could be by plan too, right? Because now it's just the 13.59. So that's or 49. That's what we're considering.
Go ahead, Ollie.
just noting that we're just getting through the best and final stage. So if we could get that information as early as possible, we need to really get to final decisions by the next board meeting. So that would be helpful.
I just
And I have-
also think, oh, go ahead, Sean.
I just want to point out, like, to the comment, like, this is uncommon. It's like, over my history on the board, it's not that uncommon that Kaiser comes in high early. So I just want to recognize, like, that that's never going to be acceptable. And it's like, but we play that, we do that. This is super disappointing. And we kind of had said best and final. So I look forward to hearing different numbers, but a lot of the industry is going through a lot of things. That is true. And this is the integrated system, and it has one of the worst renewal rates. And that's not, so we start to wonder, like, what is the benefit of the system? So let's have a good conversation next month, but it's just disappointing we got to this point.
Thanks for your comment, Sean. So given that, I do think it's still helpful for us for Mercer, for you to share what we're looking at as potential plan designs, even if we don't vote on anything today, so that we're clear on what the rates would be when we do the final rate setting in May, or the final vote around the plan design. Does that make sense?
Mm-hmm. Yeah, so the next slide has the plan design changes that we obtained. So these were options that we requested from Kaiser after reviewing the plans. And so we've got them split between the full-time HMO and the full-time deductible plan. And you can see that there's not a lot of rate relief for some of these changes. So we looked at office visit copays, the emergency room copays, prescription drugs, the out-of-pocket maximum. And so we settled on, based on what we received, is we're recommending making the change to the ER copay from 75 to 150. So that's option one. And the reason we're making that recommendation is because that would align across all plans, because the MODA and Providence plans are at 150. Another consideration out of these options is the prescription drug copay on the HMO plan. The change may be a little too much to adopt this at this point, but we wanted you to see what it would look like. So currently, the copays are $1 for generic and $15 for preferred and non-preferred brand, and then $50 for specialty. And so we asked Kaiser to price $10 generic, $30 for brand, non-preferred brand, or preferred non-preferred brand, and then $100 for specialty. And you can see there's a 2.1% rate reduction to make that change on the HMO plan. Another option to consider, and since we're going to be going back to Kaiser again about the rates, is something in between, similar to the deductible plan, which would not provide as much rate relief, but would be more middle of the road and more in line with the deductible plan, which it would not be as significant of a change. So it'd be going from $1 to $5, for example. So do you have any questions about these options as we have them outlined, or? I'm not seeing any.
So to be clear, this is because Kaiser came in so high. These are options to try and lower the rates.
Exactly.
Is that correct?
So what the percentage
yeah,
is showing is the percentage that'll come off of what they've quoted on the rates. You can see, like, for the ER copay, option one, for the HEM plan, it's 0.22%. Yeah.
Right. Okay. Well, that sucks. But thank you.
Yeah.
And can you hear me now? Sorry, I was having trouble getting off mute.
Yes. Yes, can hear you,
Okay.
Sean.
So it sounds like, we should be looking, this will look different in May. That's my understanding from what I'm hearing. And I'm going to go off the camera. He said improves my quality of speaking. So where is Kaiser on the anti-obesity drugs? Because I didn't see a slide on that.
They
so Kaiser,
don't.
oh, go ahead,
Go
Sally.
ahead. I was gonna say they don't
You're
cover
good.
them, and yeah.
They don't have plans to remove that exclusion. So if ultimately next month, when we talk about GLP-1s again, there's a decision to adjust the exclusion on Providence and Moda, it would only apply to those two carriers, not Kaiser.
And one interesting point when we were looking at the data, there were some members who did not have a diagnosis of diabetes, type 2 diabetes and obesity, but were getting GLP-1 drugs. None of them were on Kaiser. So, in terms of managing drug costs, I think what we've shown historically is that Kaiser has been very good at managing it. And I think, the data kind of has been showing that over the years.
And there are prior auths in place with the other carriers too, which sort of had us scratching our head a little bit. It was not a huge percentage of folks who don't have a type 2 diabetes diagnosis who also had the GLP-1s, but it wasn't zero. And so that's another thing that we're continuing to look into.
Do those individuals have obesity or higher levels of obesity diagnoses? For example, were they faced with the choice of surgery or trying this medication and getting exceptions put through for treatment of obesity at the higher levels even before comorbidities?
I think that's possible, Don. It would require an exception based on the prior auth, but that's possible. Yeah. We should know by this time next month. Yes, Kate.
So can you restate, or if you didn't state it, tell me the difference between the copays that we do with it for parity across plans? Because the 75 to 150 sounds really steep to me. So and also, is this something that we could table and wait to see how Kaiser's plan comes back and just kind of, so two questions. One is where are the other copays, because I do want to have parity and I don't, Andy, I think you were the one that said it. At least you were the one that had a yellow box around your head when I heard it, but I kind of agree. I'm not a huge fan of that. And then two, make sure that this is something we can table if we're going to get updated rates here in the next couple of weeks.
Yeah, I think we can
Yeah, so-
table it, Kate. And then Sally, did you want to comment on the parity piece?
Yeah, yes. On the full-time plans, they on Moda and Providence, they do have a 150 copay for ER. So it is consistent.
So one of those that jumped out to me as potentially hard to bear and maybe with an equity impact was the specialty drugs going from 50 to 100, because the people who are getting those are typically already also bearing the weight of some of the more chronic and complicated and pervasive or having impact on quality of life illnesses and conditions, if I understand correctly, which drugs fall into those classes. Am I missing that?
Yeah, so those are this. I don't know if I'm going to be answering your question, but they would be the specialty drugs. So these are the higher cost drugs that would have the higher copay. But I think when we circle back with Kaiser, what we'll do is come up with a middle of the road design that's more similar to the deductible plan, which would take it. It would be it would stay. It looks like it'd stay to $50 if we did that, but up the $1 copay to $5 and potentially looking at the $15 copay and increasing that. So we'll come up with a different option to review too, because that is a jump. But this at least gives you a sense of what it would take to make a difference in the rate. So making those changes would make an appreciable difference in that on the traditional plan.
So,
In one area, go ahead.
I was just going to say, I just appreciate that we're going to need to look at more options. And if the board, any information that can be shared with the board, I know we usually get the packets right before our next meeting. But if we do in fact get changes for Kaiser sooner than that, I think I know I would appreciate seeing it sooner than later. And my guess is other board members would as well.
We can do
The other
that.
piece of context I'll add before we move on from this slide is that when we requested these plan design changes, we weren't aware of the composite coming under 3.4%. And so now that we are under 3.4%, I'm not necessarily saying that we don't want to look at these changes, but maybe there's a little bit less urgency. But before the composite came down, we were flipping rocks, you know, and so the Kaiser renewal is coming in really high. And
Before
so
you go in too far to that, the rate renewal for Kaiser is too high. It is exceptionally too high. And I don't want to start like, because the composite rate, this and that, like every one of the plans has a responsibility to come in with rate renewals that are reasonable. So I hear what you're saying. And I think we should still talk about it.
yeah, totally. I don't disagree. Just wanted to provide that little bit of history, but you're right. You're absolutely right. Okay, Sally, do we want to move on to the travel and lodging?
I think so. Rose, you ready? So this next slide will be one we've talked about before. So this is the travel and lodging benefit, and the purpose of it was to come up with a kind of a condition agnostic benefit across the plans in order to support needs for travel, whether it's for reproductive services or other health services. And so we had two options that we presented for the MODA and Providence plans, and then Kaiser has their standard option. And so we're recommending option 2, which has several options within it in terms of coverage. It would provide coverage to members who, for whom there's not an in-network provider within 50 miles of their home. It would provide coverage if the service is not available in their state of residence due to law or regulation, and where it's permissible to receive it in another state. And then finally, if they're receiving services via a COE, so some sort of specialized service, say like transplants. So this means the plans would have one design for travel and lodging rather than separate coverages depending on the type of service. And so this would have a cap of $5,000 annually. And so you can see on option 2, there is negligible cost under the Providence plan estimated, and MODA is estimating about 0.63% or about $1 million in costs. And then Kaiser's is an option that provides the option for travel if it's needed to get services outside the Kaiser system. So, and this is one that does require board decision. So does anybody have any questions about these?
So if I understand correct, it says other health services. So this would be basically not just, and I'm not picking on it, not just reproductive, but any type of health service that I would need that's farther than that amount, this would cover that.
Would cover that, exactly.
Okay, thank you.
Thanks for the clarification. Do I have a motion on this? So if we're going to move this and change the travel and lodging benefit, we do need to make a decision.
You went back on mute, Greg.
Do we currently have travel and lodging, or is this all brand new?
You currently have travel and lodging, but it's different between the plans. And I don't have it memorized on the top of my head, but for example, there's a benefit for, I think for transplants, there might be a benefit for bariatric surgery. And so it's not one, and they're different benefits. It's not comprehensive benefits. So this would give one comprehensive benefit.
Right, we're trying to get everything more on an equal basis between all 3 plans, correct?
Correct.
Okay, so I make a motion, we accept.
And
Go ahead.
the Mercer recommended option 2, is that the one you're recommending, Greg?
I was going to recommend that we, because of the small difference in price, that we recommend. My motion is that we adopt option 2, which was Mercer's recommendation.
Okay. Thank you,
Second.
Greg. Do I have,
Second.
okay, we've got, I think Sean is beat out Dawn as the second. So Dawn, how do you vote?
Approved. Thank you.
Thank you. And Greg, you did the first. Chicky? You know, Chicky told me she had to leave at noon, so my guess is she had to hop off the call. We still have a quorum. Andy?
Approve.
Kimberly?
Approve.
Kate?
Approve.
And Sean, you are our second, so the motion passes. All right, thank you.
And so next is dental. So Delta Dental, this is your self-funded dental plan. MODA or Delta Dental has come in with a little bit lower fee, reduced it by about 11 cents. So now the increase is 1.5%, and then the fee will be $6.67 per employee per month. In the process, we, after the conversations about the access issues with Willamette Dental, we originally had asked for a couple of orthodontia options that increased the lifetime maximum for ortho. And then we decided with this round to look at a couple other options that might more closely replicate what Willamette Dental has in their plan. So we asked for a copay. So option 3 is a $2,500 copay, and option 4 is a $3,000 copay. And you can see that actually the costs went up because what's happening with these two compared to the first two options is that the member would pay the $2,500 or $3,000, the copay, and the plan would pick up the balance of the cost. Whereas under option 1 and 2, it's a shared cost. And so there's just a lifetime maximum, and any balance over that 50% would be the member's responsibility. So as a result, given the costs associated, we're recommending declining all of these options at this time, and considering maybe taking a look at a little closer to this down the road.
Any questions?
Questions?
Oh.
I make a motion to accept this as presented from Mercer and decline those recommendations on the ortho.
Thanks, Kimberly. Do I have a second?
Second.
Dawn seconded it for us. Thank you, Dawn. So Greg, how do you vote?
I vote yes.
Okay, Chicky is not here. Andy? I think, Andy, are you still with us? I'll circle back to Andy.
Sorry, solicitor.
No,
Yes.
no worries. Yes, okay.
Sure.
Oh, or do you need me to restate the motion, what we're voting on, or were you good?
Oh, no, I heard it. I just couldn't get to the mute.
Got it. Okay. Andy's a yes. Kimberly, you moved it. Kate?
And just to make sure, yes is voting to accept the recommendation to decline the changes.
That's right. A yes is a no.
Okay.
So yes is declining all of the options that were put out there.
Okay. Then yes, I vote that way.
Okay. It's unanimous. Oh, Sean, sorry. Sean, go ahead.
I vote yes.
Thanks, Sean. Sorry about that. I think everyone is now accounted for. All right, I think we're ready to move to the next slide.
Which is going to be the Kaiser Dental. And we don't have our little decision box on here, but I think there is a decision to accept. And so as Emery mentioned earlier in the meeting, Kaiser came in with an adjusted renewal of a 2% premium decrease. And this is calculated off of a capped decrease of 5%. And so I think we're recommending, Emery, we're recommending accepting.
Well, we don't actually vote if it's just a decrease and not a change in plan design. Is that right, Ollie? We don't need to vote on this one?
You should still vote.
Okay. All right. Then I need a motion to accept the premium decrease. I have a motion.
So moved.
Dawn, and do I have a second?
I can
Greg
second. It's
seconded.
Kate. Oh, Greg got it.
Greg got it. Okay. So Andy, how do you vote?
Approve.
Kimberly,
Approve.
Kate,
Approve.
Sean.
Approve.
Okay, so we've accepted the premium decrease. Okay, now we're ready for Willamette.
Now we're
Thank you.
ready for limit. Okay. And there are two decision points, I think, here. So first is just reiterating that Willamette Dental is not asking for a rate increase for 2024. So it's going to be a rate hold. But what they are asking about is they currently have a program in place to waive the office visit copay for that for new patients. So really it's a get acquainted visit to get people into the system, get them so they're established in one of the dental practices. And this is something that occurred in 2022 and is currently in place now. So there are people who are taking advantage of it this year. And so the question, I guess the vote is to accept the renewal, and do you want to continue this copay waiver for 2024?
And there's no cost associated with the copay waiver, right?
No cost
No.
associated.
Yeah. Do I have a motion?
This is Kimberly. I make a motion that we approve Willamette Dental Group's renewal and plan enhancements.
Thank you, Greg. Oh, sorry. I thought you came off mute. Do I have a second?
I was going to, I'll second.
Okay. Thank you. Dawn, how do you vote?
Approve.
Andy,
Approve.
Kate,
Approve.
Sean. Oh, you came off mute. I didn't hear anything. Maybe that was me.
Approve.
Okay, thanks, Sean. I actually have a question around Willamette that I thought we had brought up, but maybe we hadn't, and it was coming around travel. Did we hear back from them on that? Because we know that we have parts of the state that don't have access to Willamette Dental. I mean, they have access theoretically, like they can sign up for it, but then they have to travel because we've had offices close. So was that conversation? And I'm sorry I didn't bring it up a minute ago before the vote, but I just didn't want to lose track of that.
So yes, we did discuss that with Willamette. They do not have the ability to implement a travel benefit. So we explored that. They did confirm that 10% of PEBB members are currently traveling 60 or more miles to visit their clinics, and they also did reaffirm that they don't have any additional office closures. And so this all came from the Roseburg clinic closure, as you mentioned, Siobhan, and so they reiterated that. From their perspective, it was a sort of unique situation, one-off closure. So we did explore that, and when this also is, in part is why we explored with MODA introducing a copay on the orthodontia, but there were just sort of too many downstream implications around future trend for Delta Ortho, which is why we recommended declining that benefit from a couple slides prior. So I guess I'll pause there. What questions or thoughts do you have?
Okay, no, I appreciate that update. And as a reminder, MODA is Delta. You said MODA, but MODA and Delta are the same, right?
Sorry. Yes. Yep. Yep.
Yeah.
Sorry about that.
Just wanted. Do folks have any questions around that? I brought that up because we've heard from some members in the South Coast area, including Douglas County where Roseburg is, and also Coos and Curry counties. So it sounds like there's no relief for those folks at this point around dental and travel. Sounds like we should. Go ahead, Greg.
I think it's something we need to, I mean, we're into 24 and it's going to be a bit, but I think it's something when we start these again or later this year, beginning next, something we really do explore with them.
Yeah, something we need to continue to look at. Thanks, Greg. All right. Sounds like we should move to vision.
Yes, next.
Oh,
So
and sorry, I do want to know, we had a 12:15 stop time for our meeting, so I just want to be mindful. is the board open to extending this to 12:30 so we can get through the rate renewals? I'm seeing Kate and Greg nod, Andy nod, Dawn, Kimberly, yes, I see all of you, and hopefully Sean can stay on
Yeah.
as well.
Yep.
Oh, okay, great. Thank you all for your patience. It's a lot to get through. All right, let's move to vision.
Okay, so we'll talk fast. So vision, there's no change on this slide. We're recommending the fees staying the same. So we're recommending accepting the renewal, but VSP came forward with a plan design suggestion. We're recommending declining that because there's already enough of a different benefit differential between the base and the buy-up at this point. It doesn't make sense to increase the cost to the members.
All right, thank you. Do I have a motion?
Express of time, I make a motion we accept what Mercer is.
Okay, do I have a, thanks, Greg. Do I have a second?
Second.
Okay, thanks, Sean. So the motion in front of us is to accept the Mercer recommendations on the VSP. Dawn, how do you vote?
Approve.
Thank you. Andy?
Approve.
Thank you, Kimberly?
Approve.
Kate?
Approve.
All right, thank you. I think that's everyone since Sean was our second and Greg was our first. All right. I think we are on to the standard life and disability.
Yes, we are. So I'll just quickly, so just as a reminder, at the last renewal, PEB increased the basic life benefit for all employees from 5 to 10,000. That is a PEB provided benefit. The rest of the coverages offered through the standard are voluntary. So that means employees who elect any of this coverage, whether it's voluntary life, short-term disability, long-term disability, they pay the full cost. The overall aggregate increase is a little over 4.5%, but that doesn't take in consideration the rate reduction on the STD plan. These rates, this renewal is guaranteed for 3 years. It was initial 2, but they've agreed to a 3-year renewal, which is great news. And so what I'll call to your attention is the life insurance lines of coverage are not increasing at all. The short-term disability is actually going to go down almost 80%, and that's due to the implementation of the Oregon paid family leave in September. So as of September 1, the rate will go down. And then the long-term disability plans are going up because they are not performing particularly well. They've got pretty high loss ratios. So if we were to go, the next couple of slides are the actual rates. And so this just illustrates the rates for the life and disability. And then the next is all the voluntary life plans. And then the following 2 slides, I won't go into any detail, but they provide some detail just on how the plans are performing, which the life plans have been performing well. And it's really been the LTD plans that haven't been. So there's some observations and some charts so you can see how the plans have performed. So in the interest of time, I won't talk anymore, but anybody have any questions or?
So I just want to make a comment, just to reiterate, the long-term disability plans, as well as the short-term disability, those are all things people choose.
Mm-hmm.
And they don't impact our composite rate.
They do not.
That's correct. Yeah.
Just want to confirm that. Do I have a motion around the standard renewal?
This is Kimberly. I'd make a motion to approve the renewal as presented by Mercer.
Thank you, Kimberly. Do I have a second?
I'll second.
Thanks, Andy. All right, Dawn, how do you vote?
Approve.
Thank you. Greg?
Aye.
Andy? Oh,
I
go ahead.
seconded.
Oh, you did. Oh, sorry. My bad. I'm losing track. And Kimberly, you made the motion. Kate
Approve.
and Sean.
Approve.
Great. Thanks, everyone. I think we have Weight Watchers next.
Yep. So this is no difference in this slide. This outlines the program, the core and the premium program offerings. And on the next slide, our follow-up after the last board meeting with both Weight Watchers and WebMD was to ask about pricing based on member engagement. And we had a call with Weight Watchers where they took us through their process. And what we learned is actually that 1.5 million that they're quoting for 2024 is based on member engagement. That's how they develop the rates. And then what ends up happening is that cost is apportioned out over the 3 plans based on enrollment. So, so we are still recommending renewal for 1 year, renew for 2024, and then evaluate the effectiveness for 2025. So I don't know if anybody has any questions about it, but I want to make sure we did follow up with them.
Thank you. Do I have a motion to continue Weight Watchers as is?
Make a motion, we continue for the 1 year.
Okay, thank you, Greg. Do I have a second?
This is Kimberly. I'll second that motion.
All right, thanks, Kimberly. All right, Dawn, how do you vote?
Approve.
Thank you. Andy?
Approve.
Thank you. Kate?
Approve.
Thank you. And Sean?
Approve.
All right, motion passes. All right, WebMD.
WebMD. So we also followed up with WebMD and asked the same question. So this slide's the same, it's not changing. So this just outlines the current program. And on the next slide, there's no change in the pricing. But we did ask WebMD whether they were willing to look at their pricing methodology and look at taking into consideration true engagement. They said they were willing to do that. They didn't provide us any pricing because their willingness to do that is predicated on PEBB committing to more rigorous communication about the program to the membership. So at this point, no change. It's still 25 cents per member per month. Estimated total cost about $305,000. We'll note that we recently learned that WebMD did miss 2 of the performance guarantees through MODA. We haven't heard anything from Kaiser or Providence yet on anything outstanding with them, but 2 measures were missed, was the registration performance guarantee and the timely reporting. And again, on this, we're still recommending to approve for 1 year and then to take another look at the effectiveness for reconsideration in 2025.
Any questions about that? Are them missing their performance guarantees reports? Sean, go ahead.
Yeah, I don't know. I don't know if I want to kick it down the road one more time. Like, I want this to be tied to actual use, like member participation, and I don't really feel much inclined to like 1 more year, just kind of see what happens. I'll defer to the group, I guess, on that, but I don't know. I feel pretty frustrated about it. I don't know if waiting until next month to finalize it would help them find their pen and paper so that they can actually make a proposal or whatever, but I don't know. That's my thoughts.
Thanks, Sean. Andy, go ahead.
I agree with Sean. I think it sounds like this has kind of been going on and it hasn't really been effective. So I think it's maybe done.
Any other comments? I guess, yeah, go ahead, Greg.
The only thing I would say is if I agree with both. The only thing I would say is if we want to get, because we had nothing back from Kaiser or Providence, if we can see if we can get, if there's more reports from them that are, that come back maybe more than 2 or 3 or 4. I don't know, because we're not sure what they've missed with them. So if we could see if we could get those by next month and then make a decision, I think that might give us more of a idea of what we really want to do. But I'm in agreement to kind of not today to vote on this.
All right, thanks. Thanks, Greg. And Margaret, did you want to respond on that?
Yeah, just to add some detail on that, we did receive some information from Kaiser just late yesterday around the guarantees. So in the WebMD contract, all 3 carriers have the same guarantees. And the vendor did miss the same 2 guarantees for all carrier contracts. So that registration performance guarantee and the guarantee with 1% of fees at risk tied to timely reporting. So that's kind of consistent. What we're sort of waiting for is these relate to last calendar year, to 2022. So we're waiting for basically the settlement in terms of like the calculations on the dollar amount of fees at risk returned. So we do still have some information outstanding on that, but I just want to clarify that the guarantees are consistent and they were missed across all 3 carriers. It's basically the same agreement for the vendor for
Thank
PEBB.
you.
Thanks, Margaret. And will we have that information by next month?
We should have it by next month. Yeah, it's coming in right now. Like April is sort of the time frame to for they're working on that. So it's in process, and I will likely have it before next month even. But so just wanted to clarify, we don't quite have it all, but will imminently.
Okay. So I know the anti-obesity medication will be a big discussion next time. We'll have to dig into the Kaiser renewal next time, and we can add this to the list as well, it sounds like. Were you going to say one other thing, Margaret? Your hand just popped back up.
No, my computer just won't cooperate, so you can
no
ignore that.
worries.
I'll turn it down.
All right. Hand it back to you, Sally.
Okay, well, I think, so are we going to defer this to next month? Is that what I heard?
Yes, yes.
Okay.
So I think we've moved through all of the decisions for today. So do you want to, one of you want to recap where we are and what we need to do next month? Before we
I
move
can
to
start. Andrew, do you want to, or do you want me to start?
Yeah, you
Yes.
start and I'll jump in. I got a couple notes too on that.
Okay, so, do you want me, so Siobhan, do you want me to go through decisions or just what we're going to cover next month?
I think it would be helpful to go through what we're going to cover next month. We've already extended the meeting, and we do need to give, I need to check to see if there's public comment as well, because we have to make time for that if we've got public comment. So why don't you go through what is pending?
Okay. So what I have is that we are going to look at the RX savings solutions. We're going to look at the pricing on that and look at ROI guarantees. We're going to do some more exploration on GLP-1s for all the 2 plans, Moda and Providence. We're going to do a lot of digging in on data there. We're going to do some more work on Behavioral Health 360 to understand why the fees are different on there, and really whittle down to what's being provided in those fees, as well as look at the cost for Spring Health as a standalone option. We'll be circling back with Kaiser on the options and revised renewal potentially. And then we'll be talking about WebMD. I think that's what I have. Andrew, did you have anything else to add to your?
I did not. Yeah, you hit on every item I had. So, yep.
And then I'm going to just add one more, and I think we've talked about it in previous, maybe it was January, but it's the IVF and the buckets for pharmaceuticals versus the procedures, because this is the first year that benefit was added. We've had people exceed the pharmaceutical cap. The plans handle it differently. And I think we needed another, I don't know if it impacts rates at all, but we needed to have the discussion about what those buckets look like, right? We have.
Yeah.
Okay.
Got it.
Okay. Yep.
Thank you. And Rose is letting us know there's no public comment. Thank you, Rose. And we are going to get the CIAO work streams update and legislative update over email. Is that right, Ollie? Okay. I see you nodding. Thank you. And just really appreciate all of you sticking with it. This is an intense meeting. It's a lot of information, and we're going to have more discussion in May to make further decisions. And just really want to appreciate you all for digging into this and for Mercer for getting information in front of us. I know the carriers continue to partner with us and work with us, so it's a lot. And there's much more to go through in May, so thank you all. And I will officially adjourn the meeting.
Thank you.
Thanks, everybody.
Bye.
Have a
Bye.
great day.